One of the main functions of a neuropsychologist is to perform neuropsychological testing. People are referred to me for a variety of reasons. The components of a neuropsychological evaluation include assessing intelligence, attention and concentration, language and speech, memory, processing speed and ability, ways of learning, the executive function, which includes planning, decision-making, time awareness, impulsivity, patience, emotional regulation, looking at visual, spatial, and motor abilities, sensory processing, modulation, and integration, and as well as personality and behavioral and emotional functioning. Sometimes when someone has a brain injury, it is important to determine what their baseline functioning is after they've had their brain injury. The brain injury could be anything from a stroke to an aneurysm, to having multiple seizures, cancer, a sleep disorder. Just a number of different kinds of conditions can cause brain dysfunction. And so my role as a neuropsychologist is to determine a person's strengths and weaknesses in order not only to get that baseline, but also to help plan for treatment, for cognitive rehabilitation and cognitive retraining. I also receive referrals for pre-surgical evaluations. I have received a number of referrals to evaluate the elderly for dementia, including to determine the form of dementia that may be existing in these individuals, to assist with treatment planning and to help keep these adults as independent as possible for as long as possible. The first component to my pediatric neuropsychological evaluations is an extensive parent interview. I meet with the parent or parents of the student, and I ask many questions about the student's pediatric history, whether it be the medical conditions they may have, their academic struggles, their social, emotional growth, any problematic behaviors, their strengths. And I use those bits of information to be integrated within the whole neuropsychological report. The next component is the actual testing. I test these children and adolescents over 2 sessions. These sessions are anywhere between an hour to 2 hours long each. And during those times, I assess intelligence, achievement, learning and memory from both an auditory, verbal perspective as well as visual. I also provide parents with questionnaires to complete regarding the student's social, emotional, and behavioral functioning, and give parents similar forms for the student's teachers to complete as well. These form a comprehensive assessment of the child in which I determine what the child's strengths and weaknesses are, whether there's any learning disabilities or cognitive disorders that may have been present since birth, whether there may be ADHD, Asperger's or autism spectrum disorders, if there's any emotional functioning or behavioral components to the student's difficulties in school. And then I interpret these reports after they're scored. I set up another meeting to meet with the parents about 2 weeks after the testing is completed to go through these results, and then I write a comprehensive report. I make academic service and accommodation recommendations within the report to make it easier for the parents to get what they need. Common outcomes at a school level when the school staff use the recommendations of my reports are things like speech and language therapy, or accommodations at school for the child who may need sensory breaks or may need a squeeze toy in order to pay attention, or may need permission to chew gum in order to be able to process what he's hearing in the classroom better. Other services are discipline policies, alternate physical education classes, remediation for math, writing, and reading, social skills training, behavior modification plans. Those are just some of the common outcomes for IEP meetings. So the components of cognitive rehabilitation include using the neuropsychological evaluation results to target those brain functions that have been impacted negatively and trying to recover them or to learn compensation or accommodation techniques for those losses. Some of the components that are involved with cognitive rehabilitation also include cognitive retraining, which is what I call PT for the brain. I try to include patients and their family in the education of how to manage some of the brain injury symptoms. I do vocational counseling. I work with families and supervisors to bring the person back to work. I also work with the development of academic accommodations if the person is still in school. Cognitive rehabilitation also includes activity pacing and planning and leisure planning. Social skills retraining sometimes, or referrals to psychiatrists or assisting with emotional disturbances that can occur with a brain injury. My version of PT for the brain, cognitive retraining, includes the use of computer programs and games that you can buy on the market, as well as iPad and iPhone applications. So when a patient meets with me for cognitive retraining, I use the results of the neuropsychological evaluation to focus on specific programs that will target the person's areas of deficit. I have taken many different computer programs now and have categorized them by brain function so that it makes it easy for me to choose which type of programming to include in my cognitive retraining. So each of these programs that I develop specifically addresses that patient's cognitive impairments and tries to improve those specific pieces that may have been adversely affected. Social support is extremely important in acquiring lost brain function. Traditionally, behavioral medicine is known to be a field that works with people who have any sort of chronic medical condition, whether it be chronic pain, infertility, sleep disturbance, obesity, any sort of medical condition that is chronic in nature. It also addresses people who have very chronic medical conditions, and by that I mean lifelong, that people need to get used to having. So that could include multiple sclerosis, fibromyalgia, heart disease. When I treat someone who has a chronic medical condition, I address their illness in a number of different ways. For example, I like to adjust their cognitions or their way of thinking about their illness so that it's not such a catastrophe. People can learn how to work with their illness and embrace it so that they can move forward in all aspects of their life. The overall goal is for the client to feel better physically and emotionally. I encourage people to become active team members. And what I mean by that is they have physicians, but they are the patient and they are an important part of the team. Their team can consist of not only physicians and themselves, but a behavioral medicine specialist, an acupuncturist, a physical therapist. All of these are important members of a team. And it is up to the patient to figure out which one of those components makes sense and actually helps them live with their chronic illness. Behavioral medicine techniques include interventions such as relaxation training and stress management. When a patient has cancer pain, we teach them a technique such as shooting the pain out the window, where you use imagery and colors and the breathing technique to take the pain and literally put it outside the body. When I treat the whole person, I address how the illness affects not only them personally, how it's affecting their role in the family. I may bring in family members to answer their questions or to help them also adapt to the chronic illness. I help the client become more active in the community through learning activity, pacing, and planning. I try to increase their social support. We touch on nutrition, especially for patients who have fibromyalgia or chronic heart disease. And I teach patients about good sleep hygiene, not only for fibromyalgia, but for a number of conditions. And there are certain populations that can be targeted with behavioral medicine. For example, people preparing for bariatric surgery. People who are going through infertility have a very difficult time and need some support and encouragement to keep moving forward. Another population that I work with are individuals who have cancer and their families. The use of behavioral medicine is an important component to increase the effectiveness of the overall treatment of a chronic medical condition. The pain management approach consists of a whole team of people now. It's an area of expertise that many different specialties are joining in order to participate in the team approach. Most pain patients are affected by chronic pain in many ways. First of all, their pain isn't always visible. Pain patients often have to convince others that they're truly experiencing pain. Then they usually have to justify to other people why they're undergoing the treatment they're undergoing, including the taking of prescription medications. Prescription medications play a significant, important role in the management of chronic pain and does not lead to addiction for many people, although some people do become addicted. Chronic pain patients also have to alter their lifestyle. They sometimes cannot perform housework or engage in roles that have been very familiar to them and their family. So there's a family adjustment. There's a financial cost, not only for medical treatment, but also to hire people to take on some of the roles that chronic pain patients can no longer do. There is a social cost. Chronic pain patients become very easily fatigued from their pain and cannot engage in a lot of the activities that they may have participated in the past. We teach patients that pain truly is in the brain. Pain sets off the body into a fight or flight response. So my role, again, as a pain psychologist, is to put those potholes in place and to interrupt the cycle. So for example, I start out by teaching patients about the brain and pain, and I validate that they truly are experiencing suffering. From there, besides the education piece, which I truly believe is very important, I find out from patients what treatments they've undergone, what they're going to go through, and I try to help them align their expectations with what true outcomes may be. The non-pharmacological piece of the pain management program is the area that I typically participate in. In addition to patient education, I teach certain interventions to increase the patient's tools to approach their chronic pain, because tension and anger and stress runs along the same pathway as pain, and intervening in any one of those areas truly helps all those other pieces too. Sometimes patients need to compensate for their pain and find alternate pleasurable activities, or to modify the activities in which they were engaged in order to continue participating in them. Another role I serve is to assist the pain interventionalist with monitoring the patient's use of pain prescription medications. Not from the perspective of how many are they taking them on time, but from the perspective of what symptoms are they experiencing from the medications, the side effects, and how to manage those, because sometimes you need to take those pain medications despite the side effects, and so we have to learn how to live with those.